Hello, I'm called Dr. Jackson Orem. I am the Executive Director of the Uganda Cancer Institute. By background, I am a medical oncologist. So I'm doing both administration, but I'm also a specialist in cancer care. Before we talk about the state of cancer care, we must know about what we call the burden of cancer in the country. And usually we talk about three key parameters. One is what we call incidence, or the number of new cancer cases. And then we also talk about mortality, the death that occurs as a result of cancer annually. And then, of course, at any one time, the number of people who are living with cancer, and that one we call prevalence. In Uganda, we depend on what we call cancer registries to come up with those statistics. But the best type of cancer registries are not very easy to establish. We call them population-based cancer registry. And as I speak, we have only about 3 that are functional. And that means that most of our cancer statistics are actually estimates. And as a result of that, we can actually guess the burden of cancer by saying, for instance, incidence, we talk of up to about 36,000 cases of cancer we see in a year. Those are new cases. If you follow those cases for 1 year, the unfortunate statistics is that up to 80% of them would have died. So that means mortality rate for cancer is still very high in the country, up to 80%. And then talking about prevalence, at any one time, we estimate that up to about 75 to 76,000 people are living with cancer annually in Uganda. And that means that those who survive add to that figure. And those are the ones that kind of strain our systems because we will keep on looking after them until when they die. And that is why the notion of palliative care is very important, because that is a very big number of people that are being looked after for cancer. And as you know, cancer is a chronic condition. That means there is need for pain control, symptom control, and all that. And that is the reason why palliative care is so important. Now, after looking at the burden, we can now dissect the different types of cancers that we have in the country. And we divide that depending on whether it is in adult or in children, and then for the adults, whether it is females or it is in males. The commonest cancers in females, if I'm to just mention 3 or 4 top ones. Number 1, of course, is cervical cancer, followed by breast cancer. And now we are seeing actually cancer of the stomach, very common, coming at number 3 in women. And then number 4 is cancer of the esophagus. And then in men, the commonest cancer, of course, is cancer of the prostate. And that is followed by esophageal cancer. And number 3 is Kaposi sarcoma. And Kaposi sarcoma is associated actually with HIV and is quite still common, despite the fact that HIV control has gained momentum in the country. And I think the incidence seems to be going down. That means the disease is under control. But the chronic complication of HIV cancer is one of them. So that means actually cancer is still going to continue to be a big problem in that population. Then when we talk about children, the commonest cancer in children for a very long time has been Burkitt's lymphoma, and it is still very common. And the number 2 are the leukemias and lymphomas, other types of lymphomas. And then number 3 are what we call the sarcomas. Those are what we call the soft tissue or bone cancers. They are also very common. and then of course followed by cancers like that of the kidneys. They are still quite common. The next aspect that we should look at in the country are what we call the risk factors, because if you know the risk factors, then you can actually prevent them. The most common risk factor for cancer overall are infections. And of the infections, you have heard about cancer of the cervix being caused by an infection called human papillomavirus. And then the other cancer I talked about called Kaposi sarcoma is caused by another type of virus called human herpes virus type 8. And then in children, the cancer I mentioned, Burkitt's lymphoma, is caused by another virus called Epstein-Barr virus. So infections are actually very common causes of cancer in the country, and they contribute up to about 42% of cancers in the country. And then the lifestyles is also a very important factor in causation of cancer. We talk about tobacco, we talk about alcohol, we talk about sedentary lifestyle. There are different types of cancers that are related to these lifestyle factors. Then from the risk factors, we move on to what I would call regional variations of cancers. We have seen that cancers tend to be, the certain type of cancer tend to be seen in certain part of the country. I give you an example. Cancer of the liver seems to be much more common in the West Nile region, the northern part of this country. And this is related to another infection, which I should also mention here, the hepatitis virus infection. And then, of course, that this may also be related to other maybe lifestyle factors that may be common in the different parts of these countries. And then, of course, factors like, for instance, how people store grains, which is usually related to cancer of the liver because of the factor we call aflatoxin, which is produced because of poor storage of grains. And you find that fungus infect those grains, and then they produce certain toxins, which when people eat those grains, it goes and then affects their liver. And if there is already an infection like with hepatitis, and then there is alcohol, and you add to it aflatoxin, that means the liver is actually over burdened by these factors, and the end result is development of cancer. That is a long explanation, but that is actually the mechanism by which liver cancer comes about. So the West Nile region, northern region, liver cancer is very common. And then when you go to the western part of the country, for some reason, which we need actually to factor out. It may also be because of how people feed. It may also be because of hygiene. Cancer of the stomach is very common. And we do know that cancer of the stomach is related to tobacco, is related to also infection with some bacteria which grows in the stomach and can actually lead to inflammation in the stomach and then development of cancer. So that is something which need to be studied further. And then in addition to that, there may also be relationship with tobacco, as I've already stated, and then also a certain type of diet. And those are things which need to be studied further. So those are the regional variations of cancers. And then another aspect which, of course, we need also to consider, going back to the burden that I've spoken about, our hospital data from the different parts of this country shows that if you look at new cancer cases, for instance, those coming to the Uganda Cancer Institute, we kind of every year see from the perspective of service up to about 7 to 8 1,000 new cases. And then we see people who are coming to seek care after being diagnosed or being on treatment. We call those revisits, up to about 36 to 37,000 in a year, which is a very big figure. And then if we divide that by where people come from, we see that majority of the people, of course, because of the location of the center, are coming from the central region. But disproportionately, we see a lot of people coming from the northern part of the country, and then followed by the eastern part of the country, and then the western part of the country. That is the reasoning that actually has helped us to begin to put services nearer to where people come from. We are developing what we call regional cancer centers. We have already established one in the northern part of the country, given that we are seeing that after Kampala or after Central Region, the northern part of the country is contributing the most number of patients. So we have put the regional cancer center now in Gulu. We are in the process of establishing another one in the eastern part of the country in Mbale, and there is going to be another one in Barara, and then another one in Arua, bringing the total to 4. And as I speak now, within the next 2 years, all these regional cancer centers will actually be in operation. So that is a very long story of where we are in as far as cancer is concerned, from the burden to the risk factors to the services that we are putting in place. The best way to manage cancer, as you rightly stated, is to have a comprehensive package. And this comprehensive package means that there has to be prompt diagnosis, there has to be adequate evaluation to know how extensive the cancer is. There must be a team that can manage all aspects of cancer, from treating using surgery, treating using radiotherapy, treating using chemotherapy, and then control of symptoms, and then control of the psychosocial aspects of the disease. All that must be done in a comprehensive manner. And the aim should be to make sure that in the first place, the cancer is eliminated or cured. And then if it cannot be cured, you must make sure that you control it. That means it doesn't increase, it just stays the same. And then you must make sure that the patient is having what we call good quality of life. Good quality of life means that the patient doesn't have pain, doesn't have symptoms, doesn't have anything which disturbs him or her to make her to all the time think about her disease and forget about all other things else. In other words, the person is not as productive as a person who doesn't have disease. Of course, I should emphasize here that the aim of treatment is always to make somebody get back to do what he or her would love to be doing normally. And if somebody can do that, and you have done it because you have treated that person properly, that means actually you have given that person what you are calling a comprehensive care, because you have restored the quality of life of that person. So that is how we look at it. And from the Uganda Cancer Institute, what do we have? We have the equipment for treating, diagnosing, and treating cancer. We have the experts in the different categories that I've mentioned that are actually well trained, and they can look after the patients properly. And then, of course, we also provide the environment which can educate our patients to know about cancer, so that they become also agents to kind of spread the information, because most of the cancers that we are talking about can be prevented. And before we can prevent it, there must be knowledge. And this information, the best way of transmitting it to the public is actually to use those who are already affected, so that they can become now agents to disseminate information. The reason is simple. For a very long time, people have not taken cancer as a very serious problem. And for that matter, there is need for us to use those models. And the patients and the people who are affected are actually the best to use to convey the message. So in the Uganda Cancer Institute, we have what we call a comprehensive community service. And the aim of the comprehensive community service is to kind of do exactly what I've said, to disseminate the information. And you cannot disseminate the information if people do not see physically or practically what you are meaning. And you must do it in a way which is simple enough for people to understand. So we do have that service, and the key pillar of that service is actually prevention. And you cannot prevent if you do not know. And that is why the dissemination of information or creation of awareness is very, very important. Of course, usually what drives away people is the cost of treatment, delivering treatment, like drugs, the cost of equipment. The Uganda Cancer Institute has developed capacity. The drugs are available, and actually, as I speak now, of the what we call the essential anti-cancers, our availability at any one time is up to about 85%. So the chances that when you come with your cancer after diagnosis, you are going to get treated based on the essential anti-cancer list of the WHO is up to 85%. So that means 85% chance you are going to have all the treatment that you need at the Uganda Cancer Institute. That leaves us with only about 15% of anti-cancers or treatment that are, the first place, very complex or very expensive, because the budget doesn't extend up to there. Those are the ones that are likely to cause a bit of discomfort, because these treatments are not very cheap. But the good news is that those who require that level of treatment constitute a very small percent, maybe only about 5% of our patients. So majority of our patients are actually covered because their treatment at any one time is available here at the Uganda Cancer Institute. Given that now we are moving into the community, that means most of our people are going to get access to their treatment. I'm saying this because one of the factors that I should have mentioned, even if you have brought all the treatment they are here at the Uganda Cancer Institute, you'll still be very surprised that a very small number of our population will actually get access to those treatments. The reason is very simple. There are very few people who are able to travel from upcountry to come to Kampala and get their treatment. There are barriers that stops them from doing that. We call those socio-economic barriers to access. And these are things like, for instance, how can I go to Kampala? If I go to Kampala, where am I going to stay? Where am I going to leave the children? Who is going to look after me from there? Those are the kind of things that will stop people from coming and accessing care. So in order to reduce some of those barriers, the Uganda Cancer Institute for a long time has been partnering with civil society to kind of mitigate things like transport need, because we have had situations where actually some well-wishers have transported patients and brought them to the institute. There was even a time when some bus companies can also give free transport to our cancer patients, so long as you can produce evidence that you are being treated at the Uganda Cancer Institute. Of course, those type of things are not very reliable, but when they come, they are usually handy to some of the patients. And then the other thing is, where do you stay when you are here in Kampala? What we have done is we have established a care home. If you move on top of the hill, you'll find there are so many patients there who are actually, so long as you are here in Kampala, you can come and stay in the care home and wait for your appointment or your follow-up, and you are seen in the clinic as an outpatient, because most of those patients are actually not inpatients as such. They are just coming for their appointments or their reviews. So they don't need to be admitted. They don't need to stay on the ward. Of course, the only thing that they need is where to sleep and then what to eat. And again, where to sleep, of course, we have provided the care home. What to eat, we are again also collaborating with civil society, corporate, who bring food, they bring things, and these patients actually get their feeding through that. And the most important thing is they are attending to their appointments, not being hindered by these other factors that I've spoken about. So, in a nutshell, those are the packages that we have at the Uganda Cancer Institute for handling cancer. That is a very important question that you have asked. I'm saying it is very important because for a very long time, because of the kind of training that most of our health workers received, they have not been asking questions regarding symptoms, especially pain. So you find that patients are reviewed by doctors and then prescriptions are made, but nobody has asked question about pain or how they feel. And as a result of that, you treat the patient properly, but the patient remains with a problem of pain. That means you are not actually treating the patient comprehensively. So at the Uganda Cancer Institute, after realizing that there's that gap which people come with following a deficiency in training, we have made it mandatory that whenever you see a patient, you must ask question and document about pain. So that is there, and because of that, the score for pain is now mandatory in all our charts for patients. So the first thing, of course, you must make a diagnosis. You must evaluate patients about pain. Once you have done that, you must make sure that there is something which can be done about the pain. And because of that, we have worked very closely with the fraternity of palliative care, like Hospice Uganda, and then got training through our collaboration with the organization like Palliative Care Association of Uganda, and then morphine, which is very key in pain control, is available, and it is dispensed on demand to all our patients. So in as far as treatment is concerned, our pain control, I would say now up to about 80% of our patients at any one time are actually having their pain controlled. And of course, we would want to move up to 100%. We don't want any patient to have pain. And then regarding palliative care, we have established a dedicated palliative care department within the Uganda Cancer Institute, and we are coordinating very well with the civil society involved in palliative care. So from the palliative care perspective, we are also doing very well. One aspect which we are now extending, because we realize that despite the fact that for the adults we are doing very well, there has been a little bit of missed opportunities in children, because children usually it's very subtle how to understand whether, for instance, a child is crying because of pain or because of some other things. So we have also extended now palliative care among those who are caring for children. Of course, there's training ongoing for all the pediatrician so that when a child comes for treatment, one of the things that they should also look out for is their palliative care needs. So that is also being done. As I stated earlier, we noticed that if we don't go into the community, then we cannot actually prevent cancer effectively. And we started what we call the community cancer services. And the main aim of the community cancer services is actually prevention. And of course, we can divide prevention into a number of areas. The primary prevention, which is to make sure that, nobody gets cancer. And of course, there, the key tool that you use is to make people aware, especially about the risk factors that cause development of cancers. So our team is involved in educating the public. Of course, we do also educate people who come here at the Uganda Cancer Institute, but we focus at the community, and that's why we go out into the community. We realize that for us to be effective in the community, we must focus mainly our training onto the health workers who are there. So our program now is developing training manuals as well as developing the what is needed to empower health workers at the lower level, because these health workers at the lower level are the ones who interface with the community members. So we are doing that effectively. Then, of course, number two in prevention is to make sure that you make diagnosis promptly. So here at the Uganda Cancer Institute, we do have, for instance, those who come because they want to be screened, we are providing the screening services. Screening is very important because it helps you to catch cancer quite early. So screening services are available, and that is coupled with diagnosis. And diagnosis is usually done through laboratory, through taking of samples, and then examining it and making sure that the result come out quickly. And then the patients are also evaluated quickly so that treatment is given and you can cure the disease. And that is actually part of what we call secondary prevention. And then at the third level is to make sure that you control, I've already said, the symptoms and all that, and then you enhance the quality of life of the patients. So all that we do here at the Uganda Cancer Institute is geared towards at least improving the outlook for our patients, and then eventually, of course, the outcome. So all those are the kind of preventive measures that we are putting in place here at the Uganda Cancer Institute. But overall, we want this to fall within what we call the National Cancer Control Plan, because the National Cancer Control is a continuum which starts at the extreme end, prevention, the primary prevention I've spoken about, and then it ends at quality of life, as well as making sure that palliative care is provided to the patient. So we kind of operate within this bandwidth, which is called National Cancer Control Plan. There are three pillars on which the Uganda Cancer Institute operate. We are first and foremost actually a research institution. That means we kind of look at new ways of addressing the issue of cancer by coming up with a new treatment, new drugs, new devices, and all that. And then we are also an educational institution. We train. We are actually now running programs like, for instance, fellowships where we train doctors to become highly specialized medical practitioners. And then, of course, we also provide the treatment, which I've said, the care. And then I should also add that that goes also along with the prevention, which is done through our comprehensive community cancer service. Now, there are so many researches that we are doing, and this can be divided into basic research. Basic research is looking at, for instance, a molecular aspect of the disease so that you can identify the key areas which you can manipulate in order to treat. So we do have those type of researches that we are doing. And then we also have what we call clinical trials. Clinical trials are testing new drugs, new devices, or modifying the old ones, making them work in a new way. We also do have clinical trials that we are doing, and a number of them are actually showing us how we can treat cancer better. And then we have also innovations, like, for instance, new devices that we are developing here at the Uganda Cancer Institute, which are being used for instance, how to diagnose like cancer of the cervix, and then using, for instance, things like mobile technology to improve or quicken diagnosis. For instance, for cancer of the cervix, we do have those type of research that we are also doing here. And then we also have research on medicines, which include also, I would call, antiseptics, antibiotics. There are a number of them that we have developed here at the Uganda Cancer Institute that are actually now going through approval process by the National Drug Authority. And very soon we are going to be calling the media to kind of show them. And we do think that despite the fact that the focus is on cancer, this type of medication can actually be used for other care, especially for wounds or antiseptics and the like. And that will be our contribution to show that, in addition to cancer, we can actually expand the scope of what is done here at the Uganda Cancer Institute to other areas. Yeah. And then there are also research that we do for discovery. For instance, new risk factors for cancers. We are looking at them. We are looking at the spread of disease within the country. As I said earlier, we use cancer registries to understand that. So a lot of research is being done here at the Uganda Cancer Institute. How do you measure the volume of research that comes out of an institution? You measure it internationally by the level of publication that is coming out of the institution. And I'm happy to inform you that as I speak now, in the last 1 year, we have over 90 publications coming out of the Uganda Cancer Institute that have been peer-reviewed. And that means they are appearing in international journals. And that, first of all, shows the volume of work, and then secondly, also shows the quality of the work, because it's not easy for you to just write something and then get it published in those journals. The fact that we are doing up to 90 within a year, that shows that we are very prolific, and that means the quality of research coming out of the Uganda Cancer Institute is quite good. I think we have had more than 4 Uganda conference on cancer and palliative care organized by Uganda Cancer Institute and Palliative Care Association of Uganda. And I must say that this is the hallmark of our very good collaboration with the Palliative Care Association of Uganda. And I want to state that Palliative Care Association of Uganda is by far our best collaborator locally here in Uganda, and we do enjoy very good cordial relationship, and that is why we are able to already do 4 Uganda conference on cancer and palliative care with the same partner. So the next one, as you stated, is round the corner. Next year, in September, we are going to be having, that will be the 5th Uganda conference on cancer and palliative care. Every other year, the quality, the content, as well as the output of the researches that are presented at the conference have been getting better and better. And then we have been getting even more people internationally coming to attend or coming to participate in this conference. I expect that this is not going to be different for the next coming conference. The importance of this conference is that it helps us to, first of all, bring out what is going on in the palliative care as well as cancer treatment spheres within the country as well as internationally. It has become a forum where people meet, they exchange ideas, and then also they do networking with one another. And we do expect that it is also going to help to stimulate academic work in the areas of cancer as well as palliative care from the research that people are doing. This is offering the avenue for all this information to come out so that it is shared for the benefit of our patients, for the benefit of the country as well as the region. And then, of course, everyone else who is actually, I would say, part and parcel of the fraternity of researchers as well as carers of cancer patients. Yeah.